Hello, everyone. My name is Chris Getchell, and I'm a director at the Office of Health Economics. Welcome back to our third and final event in this three-part series on informal caring burden in HTA, commissioned and funded by Roche. In our first session, we heard about the burdens of informal caring and why HTA should take these burdens into account when they assess the value of new technologies. In our second session, we heard about NICE's current approach to considering carer burden and some of the modeling challenges within these approaches. Today's format is slightly different. We're going to be hearing from 4 speakers representing carer, academic, industry, and HTA perspectives on future developments around informal caring burden in HTA. How can we get better at understanding it? How can we get better at measuring it? How can we get better at valuing it? First, I'm delighted to welcome back Portia Thorman. She was a participant in our first webinar. She's an advocacy lead with Spinal Muscular Atrophy UK and is one of 2 UK delegates at SMA Europe. She has a BSc in psychology, is a qualified primary teacher, and has 4 children. Her youngest child, Ezra, has type 1 SMA. Since his diagnosis, Portia has shared her experiences on social media and has worked to increase awareness of SMA generally. Portia?
Hello, I'm Portia Thorman and I'm advocacy lead at SMA UK. I am also an informal carer for my son who lives with SMA type 1. You can see in the picture there. I'm talking today about how we can reduce the burden on the informal carer. In the last webinar, I spoke about my experience, my journey as a mum and as a carer. And now we're going to look at if there's any ways we can reduce the burden. So I put this question to a WhatsApp group of families living with SMA, and I've picked out a few quotes here from that conversation. Now, the main opinion was that the children themselves are not a burden. We don't feel like our children is a burden. The burden is the lack of support in mental health, the lack of support in formal care, and access to treatment and therapies. And what it boils down to a lot of the time is a lack of money. So let's pick apart these burdens a little bit. So the first one we've got here is not receiving the right treatment at the right time. This can easily be solved by newborn screening. The difficulty is now, how do we look at these dual therapies? Now we've got our main therapies. How can we really assess what has the benefit and what the best treatments are for the individuals? There's a lack of support and understanding from society. Disabled people are very underrepresented in the media. People are ignorant to many, many things that disabled people live with. And I think that social media and disability influencers living with disabilities have really helped this, and we need to move that forward more. Isolation is a big one. A lack of continuous support, inequity in being able to get health packages, the systems holding people back and mean that they can't get what they need. We need increased funding in health and social care. We need smoother access to benefits and equipment. And we need to look seriously at how we can fix this crisis in care that is being experienced by disabled families, disabled adults across the whole spectrum. Is overwhelming. The appointments, the decision-making, the needing to coordinate appointments across a multidisciplinary team. We need to come to a point where the NHS are sharing information, a much more team around the child approach, having SMA clinics so they can see every professional at one time in one space and not having families coordinating their own care, making sure that their appointments are together. That shouldn't be the role of the carer. And if we could take that off their hands, that would be one element of burden removed immediately. Difficulty accessing appropriate therapies. Now, this is a really interesting one because the perception of the community that I'm involved in, at least, is that there's a huge inequality in access to therapy and equipment. Depends where you live. It depends on that local budget. And also in SMA, it depends on clinical opinion. With clinicians, sometimes disagreeing about what best management is, we need to bring all these clinicians together from different disciplines, and we need the patient in the center of that to find out what is the best management pathway. Because at the moment, we've got some clinicians practicing one pathway in orthotics and another a different pathway because they believe that's the best way. But to the patient, it looks like inequity. So we really need to bring them together, and with a huge role of the patient groups here, and figure out the best way forward for management of SMA. Now, the other burden is social media, because it's great being able to have spaces to share experiences. And there's nothing quite like talking to someone who's been through what you've been through. But the burden it brings is you can see different people's journeys. You know, this family might be really burdened by a lack of support, where another family has a fantastic 12-hour night care package. And we need to make sure that social media isn't exposing people to these differences and making them feel bitter and more burdened that someone's getting something that they're not getting, that it's unfair. So we need to introduce safe spaces where people can share experiences in a positive way, monitored with people that can, you know, signpost to different places that can help you out. So it is a huge problem. There's so many elements and too many to talk about in this presentation. But there are ways that society, patient groups, clinicians, industries can help reduce the burden of care. Thank you for listening.
Thank you, Portia. And as a reminder to the audience, please enter any questions that you might have stemming from the presentations, or just thoughts that you might have about any of the presentations in the Q&A section to the right-hand side of your screen. We will try and address as many of these as we can during the panel session that will follow these formal presentations. Next, I'm delighted to welcome Harith Al-Janabi. He is a professor of health economics at the University of Birmingham. He has published on methods for the inclusion of carer and family effects in economic evaluations in top international journals, and has contributed to the development of the ICE-CAP-A capability measure. Before joining academia, he worked for the Department of Health and the Treasury. Harith?
Hello, my name's Harith Al-Janabi. I'm a professor of health economics at the University of Birmingham, and I'm going to be talking about 4 issues in terms of how we include carer outcomes in economic evaluation and where we go from here. So just a disclaimer to start with, all views expressed in this presentation are my own. They don't represent the view of Roche, the University of Birmingham, or the Wellcome Trust. So the first issue is thinking about how we can make sure carer outcomes are included more regularly in economic evaluation. First helpful point would be to have a more detailed reference case from HTA organisations. This would promote a greater consistency and take-up in terms of analysts including carer outcomes within economic evaluation. We might also want to think about making carer outcomes making the inclusion of carer outcomes the default in economic evaluation. So analysts would have to justify their exclusion rather than their inclusion in economic evaluation. Because economic evaluations focus on the evaluation of costs and benefits of interventions rather than diseases, we need to also think about intervention-based justifications when we include or exclude carer outcomes, thinking about the logic by which interventions impact on carer outcomes, and thinking about the fact that carers' lives are likely to be affected by the delivery and organisation of healthcare interventions, in addition to the impact that that intervention has on the patient's health state. This includes giving consideration to factors like information, location, timing of interventions, and the role of the family carer in the delivery of those interventions. These were all factors that we identified in some recent work we did with family carers of individuals in stroke, dementia, and mental health. Here we put together a framework for thinking about the different mechanisms by which health and social care interventions can impact on carers' well-being. The impact of the patient's condition and the intervention on that patient's condition was just one of 6 mechanisms that could have positive or negative outcomes for the carer's well-being. The second issue is around the measurement of carer outcomes. It's important to measure the impact of interventions on carers' outcomes wherever possible, This provides higher quality evidence than simply transferring estimates from other settings, and helps us address problems like the current lack of data we have across different intervention areas on carers' outcomes, and potentially build up data sets, enabling us to consider carer outcomes in contexts where data cannot be prospectively collected. Of course, there are measurement issues, issues around what instruments we should be using to measure carer outcomes, and how we consider the spread of impact of the intervention beyond a primary carer to their wider family network. And also whether there's a hierarchy of evidence where we might prioritize data that comes from randomized control trial settings, for example, over observational data or data that's transferred from other contexts. Just returning to that issue about the impact of carer outcomes beyond the primary carer, we've got a brief example here. If we had a hypothetical intervention that cost £120,000, generating 3 QALYs for the patient and half a QALY that we measured for the family carer, we can see that the inclusion of the carer outcome reduces the cost effectiveness ratio from £40,000 to £34,000 per QALY. If we were able to collect data on a second family carer and found a similar impact of half a QALY for them, it brings down the ISA to £30,000 per QALY. But this ignores the fact that patients typically have wider networks of individuals that are close to them that might also benefit in some ways from interventions targeted at the patient. With a fairly typical close network of 8 people, if we made the same assumption that half a QALY of benefit was generated for all of the family network, you can see that this has a very drastic impact on the cost effectiveness of the intervention. Making this assumption would reduce the cost effectiveness from £40,000, just considering the patient's outcome, down to £17,000 per QALY if this assumption about the carer effect was made for the wider network. Fourth factor is around modelling. This provides the bridge between what we are in theory interested in estimating in an economic evaluation and what we can in practice collect data on. If we can't prospectively collect data on carer outcomes, there's an open question about how we estimate the treatment effect then on carers. Do we transfer estimates of utility from other similar disease or intervention contexts, or do we try and predict that carer outcome from the patient's data? Also, what sort of assumptions might we make, or how might we model the spread of spillover beyond the single carer? There are also issues about the timing and duration of effects on carers and whether they're likely to be the same as the effects on patients and what assumptions we make about those. Finally, I just want to consider the presentation of carer outcomes in an economic evaluation in different decision-making contexts. For evidence to be used by decision makers, it needs to be appropriate and accessible. So we need to know more about how decision-making bodies want these effects presented, and consider issues like whether to present a single or multiple incremental cost effectiveness ratio, how to present data in sensitivity analyses, whether to present data in a disaggregated format in a cost consequence analysis where different units of cost and different units of benefit would be presented separately, and how to consider factors like the distribution of outcomes, equity, and the qualitative testimony of family members within decision making. Thank you, that's all from me.
Thanks, Sarah. Next, Simone Sutherland is Global Access Evidence Lead at Roche, covering rare diseases in neuroscience. She has extensive experience in several publications within health technology assessment and health economics. She holds a PhD in epidemiology and public health from the University of Basel, where she's currently based. Simone?
Hi there, my name is Simone Sutherland, and today I'll be talking about capturing carer burden and HTA. What is the future? I'll be sharing an industry perspective. I would like to disclose that I'm an employee of Roche and a holder of stocks at F. Hoffman La Roche as well. I'd like to summarize a recent publication by Pennington and colleagues that talked about 6 key recommendations for industry and HTA bodies for the inclusion of care burden in HTA submissions. Through this presentation, I will go through each of these 6 recommendations in further detail. The first recommendation is to justify whether and why a carer's health-related quality of life is included in the economic evaluation. This is specifically to say, should evaluations specify explicitly when carer health-related quality of life is included, whether carer's health-related quality of life is included in the base case or sensitivity analysis, and also the rationale for including the carer's health-related quality of life. During HTA assessment, additional considerations that could be included in evaluations involve the evidence that the carer's health-related quality of life is of relevance, the mechanism by which carer's health-related quality of life is affected by the intervention, and one should also consider the number of carers whose health-related quality of life is affected. Another key recommendation would be to provide evidence of a carer's health-related quality of life for the population under consideration. One should consider what needs to be done. For instance, the carer's health-related quality of life should be collected alongside the patients. Another thing to consider is how it can be done by planning for collecting the carer's quality of life data in early stages of development. And lastly, why should it be done? And this is about generating evidence-specific data for a disease area, intervention, or country. Another key recommendation would be to justify the data used and to discuss its limitations. For instance, when using data from a different disease area, one should state explicitly if the carer's health-related quality of life data has been derived from that disease area. On the other hand, if data is derived from a different country, one should explicitly state the country that's derived from and explain the applicability and limitations. In both cases, the user should explain and consider all the differences of the data sources considered. Another consideration is where cross-sectional data informs carer health-related quality of life. It should justify the choice of external data used to derive comparisons. Preferably, carer's health-related quality of life data would be collected at multiple time points to demonstrate how it changes as patient health changes. However, there might be some occasions where cross-sectional data are available. For example, a survey of carers collected at one point in time. If this is the case, an analyst can carefully consider how to translate this value into the use of an economic evaluation. Again, assuming that carer's health-related quality of life would be equivalent to full health in the absence of any caring responsibilities is unlikely to be appropriate, given that the effects of aging and comorbidities. So for this reason, it's best to do comparison to age-adjusted norms, and you can present a more appropriate approach. This will reflect that no group has a mean utility of one. Another recommendation is to carefully consider the implications of the modeling approach and be explicit about the assumptions made. For instance, economic evaluations should explain how the modeling approach incorporates a carer's health-related quality of life, what this assumes about the changes in carer's health-related quality of life as the patient's health changes, and assumptions about whether carer's health-related quality of life is included in the evaluation throughout and beyond the patient's lifetime. Again, justification should be provided for the chosen approach, and all limitations should be discussed. When this is done as well, you should present disaggregated results for patients and carers using sensitivity analyses to include or exclude carers. By presenting the results for two groups separately, this allows for clear identification of where the cost and benefits accrue. Including sensitivity analysis, excluding carers or including them if they're excluded in the base case, allows the cost effectiveness to be considered in circumstances where carer's health-related quality of life is deemed not to be relevant if excluded in the base case. All of this is just to say it should be included within the economic evaluation. And if it's at least included in the sensitivity analysis, it can be taken into consideration. Finally, I'd like to give some thought to potential ethical implications of different approaches to considering care burden, primarily the care quality trap. This care quality trap means that consideration of care burden in HTA will not always improve the value of new interventions. This was discussed in the second webinar of this series. I'd also like to think about the valuation of time of individuals. When burdens to patients or carers are expressed in terms of direct or indirect monetary losses, such as loss of income or foregone societal productivity, it can mean that less value is assigned to informal carers, who may often be retired or in lower paying or volunteer positions. For this reason, it is often not considered by many HTA bodies. After reviewing the evidence base and considering the key ethical considerations, the next steps would be to call for more routine disease-specific collection of care burden and clinical trials, especially but not limited to rare and debilitating diseases. We would also recommend routine inclusion of care burden as a value element in HTA submissions. Future opportunities may be that given the relative inconsistent methods, industry can be a collaborative partner of the development of global HTA guidelines around the measurement and incorporation of care burden within HTA. Thank you for your time.
Thanks, Simone. Finally, Neil Hawkins is a professor of health technology assessment at the University of Glasgow. He's also vice chair of the UK's Diagnostic Advisory Committee and a member of the Medical Technologies Advisory Committee. He was previously a member of the ISPOR Board of Directors and has over 20 years of experience in HTA in pharma, academic, and consultancy sectors, and has published over 100 articles in international journals. His current research interests include methods for evidence synthesis, adjustment for placebo effects, assessment of diagnostic and AI technologies, and investment analysis. Neil?
Thanks, Chris. My name's Neil Hawkins, and I've been asked to talk about the inclusion of care effects from an HTA perspective. First, my disclaimers. All views and thoughts and opinions expressed during this presentation are mine personally and should not be attributed to any employer, organisation, or committee I am affiliated with. To start, to paraphrase John Donne, no woman or man is an island, especially when sick. Ill health clearly can affect the quality of life of the family and associates of those who are sick. There may be impacts on the parents, children, and spouses of those who are sick. Quality of life impacts may extend further to friends and even to colleagues, if, for example, extended sickness increases stress on co-workers. Impacts on families and associates may include psychological and physical effects, and also impacts on capabilities, our ability to do the things we want to do. These impacts may be minor or profound, depending on the nature of the illness or disease. And successful treatment may reduce the impact illness has on others. These external impacts of disease and treatment on those around the patient have been referred to as spillover effects, and they're clearly potential candidates for inclusion within HTA analyses. However, if we were to include these spillover effects as an additional benefit of treatment, we also need to include them on the other side of the equation as an increase in the potential opportunity cost of investing in the treatment. Essentially, we need to take account of any loss of spillover benefit from those treatments we can no longer fund. If we were to routinely include spillover effects within cost-effectiveness analyses, we would need to adjust the acceptable thresholds that we use to determine whether or not the treatment is a cost-effective use of scarce healthcare resources. As argued by Al-Janabi in their framework, if I have understood the paper correctly, if spillover effects were simply directly proportional to the incremental health gains enjoyed by patients, there would be no net effect on our decisions of including them. I have refrained from including equations in this presentation, but for those who do like equations, I can recommend Al-Janabi's paper for a more detailed and complete treatment. Therefore, perhaps we should focus on those spillover effects that are clearly disproportionate to the health gains enjoyed by the majority of patients. For example, spillover effects may not be directly proportional to health gains because some diseases simply have a greater impact on families and associates than others. Similarly, chronic diseases may have a disproportionate impact compared to acute, shorter-term diseases. And finally, more severe diseases may have a greater impact than mild disease. To put it technically, the utility impacts on family members may not be a linear function of the utility impact of disease on patients. Perhaps long-term support provided by informal caregivers, as and when required, is a good example of a potentially disproportionate spillover effect. And certainly most of the discussion so far appears to have been around the inclusion of carer effects rather than a wider consideration of a wider set of spillover effects. We can see that this view is shared by a number of HTA agencies. Pennington et al. In their survey of HTA guidelines noted that a number of agencies, including NICE in the UK, HAS in France, HICRA in Ireland, and ZIN in the Netherlands, indicated that care effects should be considered within HTA assessments. However, this view is not shared by all agencies. Pennington et al. Also reported that PBAC in Australia and PharmAC in New Zealand indicated that care effects should not be included. Perhaps these differences in guidance reflect different views of the scope and objectives of HTA assessment, or maybe different views on the proportionality of care effects as a function of disease effects on patients. It's interesting to look in more detail at the recently updated NICE methodological guidance. It refers to the inclusion of health effects for other people, mainly carers, when relevant. Perhaps this permits a wider view of spillover effects going beyond those impacts on carers. However, this phrase is not carried through later in the document. The guidance further states that when presenting health effects for carers, evidence should be provided to show that the condition is associated with a substantial effect on carers' health-related quality of life and how the technology affects carers. This perhaps reflects a focus on the inclusion of care effects only when they are disproportionate compared to the majority of conditions, and when there is a clear effect of the technology on those carer impacts. So, in summary, I believe in principle spillover effects should be considered. However, if inclusion of spillover effects were to be commonplace and budgets remain constant, acceptable cost-effectiveness thresholds would need to change. If inclusion of spillover effects is infrequent, for example, where spillover effects are disproportionate, the impact on thresholds might be marginal, and we could keep the same thresholds as long as we only include carer effects and maybe a minority of appraisals. The material effects on carers' quality of life probably do present disproportionate spillover effects compared to the wider effects on friends and other associates. And I'd just like to finish by saying thank you very much for your attention today.
Thanks very much for that, Neil. In the second half of today's event, we're going to have a panel discussion representing different points of view. As I mentioned, there's an opportunity for you to enter questions in the Q&A section to the right-hand side of your screen. I will quickly address the most popular question that, yes, there will be a recording of the webinar available. You should receive an email in the next couple of days with a link to the webinar. Before I get to the audience questions, I think I'll give an opportunity to the speakers. Was there anything that someone wanted to bring out either in their presentation as it relates to maybe a point that someone else made, or just something that they would directly like to ask one of their co-presenters before we get into the audience questions?
I would like to say, to me, it seems incredibly complex to come up with a way of including carer burden within any kind of assessment. Because from my personal experience, I mean, if someone was looking in on my experience and, you know, or read on a piece of paper what my life is now compared to what it was before my son had treatment, or before, you know, my life has completely changed. I lost my job as a primary school teacher. I had to have formal carers in my home. You know, my son's been very, very seriously, critically ill many, many times. But from my perspective as a carer, my quality of life is actually better, which I think some people would find very difficult to understand, because of the joy that has been brought to our family and the way my networks have come together. And, you know, it's brought something else to my life. And I know that that perspective also isn't the same for everybody in my position. Some people find it really, really difficult, and it's really negatively affected their life. So how can we represent these really polar opposite effects on our own lives and on the lives of the people we're caring for?
Excellent point. Excellent question. Difficult question. Would anyone like to offer a response to that? Or
happy to say a few words. Thanks, Portia, for the description. I suppose what we're focusing on in evaluating health technologies is the average impact that a treatment or an intervention has across a group of people, patients, or families. And similarly, when you look at an intervention, it might have quite complex impacts on different patients, and they react differently. And I think that when you're trying to take carers' impacts into account, there's potentially even more variety, as you said, in terms of how individuals respond and how their quality of life is affected. But the principle, I think, that's important to retain is that unless we find a way of trying to capture the impact on carers in a sort of through their quality of life effects, they will get ignored, and will make decisions based without any regard to what works on average for carers. And in principle, carers' quality of life can be measured using the same sorts of tools that we use to measure patients' quality of life, and sometimes we use those techniques that focus on sort of aspects of their health and broader well-being, and sometimes broader measures of quality of life that focus more on the impacts on their caring role can be used. And it's not necessarily contrasting what their life was like before becoming a carer and after, but what the impact of a treatment would have on that carer's quality of life. So taking the fact that you've got that situation that's already pre-existing, but would a particular treatment improve that in the margin, or decrease it in the margin? And hopefully you would expect that it would have additional benefits to quality of life if it was the treatment impact on the quality of life rather than the impact of being a carer.
Okay, I understand, because without treatment my son wouldn't even be here, so that's definitely improved my quality of life.
Actually, I had a thought. Thanks for asking that question, Portia, because we have focused a lot on caregiver. Obviously, that's the focus here, the caregiver utility. But you mentioned something in your presentation about access to like equipment and things like this. And I think that comes into it as well, that there is a out-of-pocket kind of expenditure that families face, that there is utility in caring for your child. You want to be there for your child. This is, of course, what you're going to do. But at the same time, there's a burden on you that you have to change your life. And during that shift, maybe you didn't have that support. And that's maybe a gap, I think, that we still need to address. It won't be solved today, or maybe that's not part of the caregiver utility spillover, but some of these out-of-pocket expenditures and another economic kind of component in economic evaluation, where we should maybe look more at that kind of financial burden that happens to caregivers in the transition. And just hearing your presentation kind of alerted me to that as well, the need for that, and point taken. So just wanted to share that.
Yeah, thank you. And that transition period is really interesting, because from all the people I work with in my role, the burden is definitely
really huge straight after diagnosis and going through that treatment process. And then as people sort of learn to live with the new normal, if you like, that burden is significantly reduced. So it's like where on that timeline as well, there's so many variables to consider.
I think from my perspective, one thing it's always worth bearing in mind is there are almost two components, I think, to, at least in UK health technology assessments. There's a quantitative analysis, the cost per quality of the ICEs. And I felt a little bit like the Grinch mentioning opportunity cost and impacts on thresholds. But also typically there is a deliberative process as part of these assessments. And again, on the my experience in committees I sit on, we have patient representatives there. And we are interested in actual patient and carer experiences. And those deliberative processes can be used to kind of influence decision making, maybe give a bit more or less leeway. And I especially think those deliberative processes are important in rare disease assessments, where again we're more likely to see, I think, disproportionate impacts on carers and families, and there is potentially more leeway to make those accommodations. Whereas when we're looking for treatments which are much more common, where the budget impacts are very large, I think there's more caution.
If I can pick up on Harith's answer. So I recognize your point that what we are valuing is the effect of treatment on a change in the carer's burden. But I wonder, in the context of the severity adjustment, is there a way to recognize not just how a treatment changes the burden on the carer, but recognize the absolute burden itself in the same way that we recognize the severity of the burden on the patient with a severity modifier? Conceptually, is there some way that we could think about combining carer and patient quality of life and saying there is some kind of aggregate severity where we're concerned about the aggregate loss of quality shortfall rather than the specific shortfall to either party? I'm making this up as I go, but I'd be curious if you have any thoughts on that sort of approach.
Yeah, I mean, I think there are probably different ways you could operationalize that sort of idea, but I mean, my starting point would be that if an HTA organization cared about severity as well as the scale of the gains, then they would need to apply that severity rule in a similar way to patients and carers' quality of life. So, for example, if you were weighting gains more highly if the starting point for an individual was below 0.5 on the quality of life scale, then it would feel appropriate to do that for both patients and carers, at least as your starting point, unless there was a sort of compelling reason for a differential treatment of how severity affected the two. I think it gets kind of quite confusing if you're trying to aggregate or add up the utilities on two individuals and come up with a sort of new rule. But my starting point would just be to recognise that there are impacts on more than one individuals, and more than one individual might be in a relatively good or poor starting point for quality of life, and then apply the weight in a consistent way.
Yeah, and I think we have to be cognizant that these things change over time. And sometimes what happens in pediatric diseases is, like, again, Portia, I'm talking about your experience again, because as a child, regardless of the improvements a treatment may bring, you still need to care for your child. You're going to still be taking them to appointments and doing these things. So sometimes we don't see this full impact on this improvement in utility because it's a bit flat. Even caring for a child that's improving or not improving, the caregiver still has a responsibility for a child. But in other instances, in other diseases where the person might become more independent, then you can start seeing this change a bit more. So I think we should be kind of cognizant or consider pediatrics a bit separate. I think it's not just about rare and debilitating diseases, but also pediatric diseases. We have to consider that the caregiver is involved full stop all the time. And I think that's something to bring to the conversation when we talk about making rules, or should it be incorporated or not incorporated. I'm saying personally, my opinion is I think the pediatric kind of treatments or technology assessments already kind of have that embedded in them. So yeah, that's something to think about.
So turning to some of the questions that have been coming in online, the most upvoted question is a fairly popular and standard one. NICE suggests that care or quality of life should only be considered in models if the impact is significant. And we all recognize that NICE has carefully stayed away from defining what significant means in this context. Does anyone on the panel have a personal opinion, perhaps, on how to interpret what significant means, or have an alternative suggestion for how to include? I mean, presumably the alternative would be let's just always include it. Neil, I think I'm going to pick on you and ask you to offer a first thought on that one.
And then for fellow members, got his hand up, but I'll start. For me, it's about if it being disproportionate, but it's not. It's above the kind of run of the common diseases and treatments we look at. Otherwise, we run into the issue if we start bringing it in for all diseases, we potentially then have to modify our thresholds, because assuming our budget remains fixed, we've still got to spread, we've got the same amount of money to spread around. So for me, it's around those diseases which really have a very profound, I think, impact on those around them. And we often see these in these diseases of childhood where the impacts are profound and unusual, as it were. I suspect it's also more associated with the chronic diseases, again, where you have to, carers and families may have to make permanent changes to their lives and aspirations and so on, compared to, say, acute diseases. And I think also where we've got evidence of impacts of treatments, that also helps us signify what's a significant impact.
I think that point about if we routinely change the scope of what we're trying to accomplish in HTA, you're right. I can see how that would necessitate some sort of change to what we view as an acceptable ICER. Does anyone else want to offer a thought on what significant might mean? In particular, I'm curious whether you think it means that it needs to change what the decision would have been in the absence of considering care or quality of life, or is it simply enough to say that, well, if we take it from 50,000 to 40,000 per quality, that is a significant change, but probably wouldn't change the decision?
I think it's hard to know what would change the decision, because it tends to be a somewhat dynamic process, potentially involving discussions around price and so on. So I think a priori, we want to identify what the impacts are and then determine whether it impacts the decision.
Can I add a perspective, Chris?
Of course.
So I think one of the important things is to always try and refocus on, in HTA, we're interested in the intervention or treatment impacts on the carer's quality of life. And one of the risks, I think, of thinking whether it's a condition associated with a significant impact on the carer is that we might miss treatments that are for conditions where the condition doesn't have a serious impact on the carer, but the intervention or treatment does, for example, because of the sort of process of care, the way it's delivered and so forth. So I don't like the wording significant. I think it's ambiguous and you can interpret it in lots of different ways. And it also creates a new bar that's different for including carer quality of life from patient quality of life. Imagine if we did HTA and said we'll only evaluate the impact of an intervention if it has significant impact on patient quality of life. So I think that's different. But I think if we do use that phrase significant, we need to think about what would be a significant impact on the carer's quality of life from the intervention, and be alert to the possibility that something about the way that the intervention's timed, delivered, accompanied by information, some of the themes Portia was talking about, and I also presented in that diagram, those factors might be relevant in terms of how the intervention impacts on the care and not just the patient's treatment, the patient's outcome themselves.
That actually touches on a different question that had come in, but exactly that Portia's presentation emphasized the process of treatment, the burden that the process of treatment places on carers. But the previous webinar and talking about the methodology here, we tend to focus on how changes in the quality of life of the patient affect the carer. Harith, if I'm interpreting your last comment correctly, you are advocating for some consideration of process burden, if we can call it that, in how we value new, not just technologies, but processes of treatment.
Yeah, I think it. Again, I think it feels like a semantic issue about the wording that we're using, but if it doesn't, it might be the aspects of the way that healthcare interventions are organised and delivered, the impact on the carer's quality of life, and that should absolutely be considered, as well as whether those interventions are changing the patient's quality of life in a way that has a knock-on spillover benefit to the carers. So any aspects of treatment and care really ought to be considered if we're considering them for patients.
I think it's particularly relevant as well in specialized technologies that have to go through a managed access agreement, because that burden of having to be part of that continued data collection definitely puts more of a burden on the carer than drugs that go straight through to license. And I think that the patients, for example, the physio assessments we have to do, that takes up all the appointment time we have with our specialist physio. So we don't have maybe a physio plan from our specialist that we might have done if it wasn't a managed access agreement, because we'd have more time with our specialist to create a plan that I could take back to the community. So it does affect all parts of his care, being on a managed access agreement.
Simone or Neil, did you want to weigh in on this one?
I think that's a really interesting point. I often heard discussions around managed access agreements, the impact on the NHS and the healthcare systems, but it's very important to recognise the impacts on patients and carers and families as well.
Portia, your comment and a comment that you made in the first webinar about we asked you a question about budget silos and how you saw that affecting the process of care and where you had to go and who delivered different aspects of that care. There is a question in the Q&A asking, to what extent to what extent does exactly that to some degree carer burden, carer quality of life is a social care aspect instead of a healthcare aspect? Do people see that as one of the primary barriers to doing this better, or is that a red herring in some extent?
I think if care was coordinated in a better way, it would definitely reduce the burden, even down to education as well. If the education provider was ensuring that his physio sessions were happening at school where he is, if the services were going to where he is, that would make our lives a lot easier. And if I only had a one-stop shop for all the equipment that we have to get and the food we have to order, if everything came from the same place, that would save us. It would definitely reduce the burden.
And does anyone else want to weigh in on to what extent they see those budgeting problems rather than more conceptual problems to be the primary barrier to maybe getting better at this?
Well, I was just wondering, you said the societal value versus healthcare, and it kind of goes back to this kind of societal versus NHS perspective, I guess, from in the UK. And if I think globally, right, because we've been talking a lot about the UK and NICE. But even from a wider perspective, It's do we need to consider a broader perspective that, especially in these rare diseases, especially in pediatrics, that it's really not just the healthcare system, and that a lot of caregivers are bearing the burden, and it's not recognized or taken into consideration, and decisions are made based on the healthcare system, and then the caregivers are expected to adapt to whatever decisions are made. So it's starting to be a bit unfair, I think, actually, from the care's perspective, right? Because these decisions are made, and then they still have to take them to appointments, and they have, so I think we're at a point in healthcare where we need to start thinking a bit broader, just because of the way new treatments are coming out and new diseases that are being addressed. And maybe it circles back to that question about significant, should it only if it's significant. I think payers, I'm speaking, from my personal experience as an economist, I think we have to be a bit more courageous and make some decisions and not just say significant, but actually say we're going to have a broader perspective, or we're going to, during early appraisal, consider the caregiver perspective. Should it be included in this? Formally assess it and something like that, instead of saying words like significant. So on each appraisal, we decide whether to include it or not, because then you have also the caregiver showing up at the appraisals and hoping, that it's taken into consideration, and that also creates a lot of, I think, angst. So I think we're at that point in healthcare decision making that it should be clear. It should, for some of these new technologies, for the diseases that we're looking at, it's not an if or maybe. But yeah, that's kind of my thoughts and personal opinion from my experience over the years and how I've seen things kind of change. And economic evaluation was always about that. It was always about just trying to value different treatments fairly for new diseases. It's let's not think, okay, is ICER going to be better, or that. It's not about that. It's, have we really collected all the value of this treatment from an economic perspective? And if we're not, then we need to reconsider what we're doing. Yeah.
Yeah, I was really excited to read the integrated care systems, the proposal of the integrated care system, because I think that addressed lots of the issues that we have. And I'm still excited to see if it actually happens.
I think
this touches on a much wider question about how we organise and fund healthcare and social services, and whether you have the advantages, if we can do it, of having integrated budgets, which would make, when you're making the choices about expenditure, then you can take into account those wider impacts, because you're also aware of the opportunity costs across those wider budgets. So I think in principle, we can see that integrated health and social care budgets will make a huge amount of sense. But in practice, obviously challenging big changes that you need to make.
So it does feel like we need a system that can bring the budget to the carer and to the patient, rather than bringing the carer to the different budgets.
So I think we're talking about a couple of issues, aren't we? Because I think, going back to your original question, Chris, it was about sort of whether it was the silos, I suppose, between health and social care prevented us from considering carers within HTA. And I think with HTA, we're interested in evaluating existing interventions, but some of the discussion here is around how we should kind of design a system to improve carers' quality of life. And I think that question about should carers' quality of life be taken into account in evaluating the benefits of HTA? Well, I think it feels like we're all agreeing it should be. There might be different approaches to that, but is HTA the best way to improve carers' quality of life alone? Well, definitely not. And then it's that different question about how, as you're saying, it's a question then about what are the different pathways and mechanisms by which health and social care delivery can improve carers' lives and well-being. And that's sort of a much broader question, isn't it, about how you design a healthcare system rather than how you evaluate health technologies.
I agree. I think my observation on that would be that you're right. So this picking up on Simone's point, that HTA works to maximize the value within the healthcare budget, but within that very constrained envelope, we could potentially come to a better outcome for everyone if we constrain that to a different envelope, I guess. Switching track here away from sort of the conceptual to the more practical. One of the discussions that Becky brought up in webinar number 2 was just some of the data challenges around this, and Harith, I think you brought that up as well. There is potentially longitudinal data collection around care or quality of life that could improve the quality of the data. Is there anything else that people see as particularly lacking in terms of data quality that could be addressed with some reasonably straightforward fixes in terms of data collection or just conceptualizing the problem?
I mean, we tend to see data being collected on a relatively small subset of conditions. So I think there's a lot of data collected on conditions like dementia and multiple sclerosis. But I think the degree to which the assumptions about how interventions might impact patients and carers' lives in those areas can then be transferred to the whole range of possible conditions and interventions that might impact on carers' quality of life is really sort of open to question. So for me, it would be about trying to collect data on a wider range of caring situations and diseases and interventions, and also generating a better understanding of that, of the wider impacts of interventions on the sort of patient's network. So while it might be possible to collect data from a single close carer, if we're interested in trying to maximize health gains, there might be health and quality of life impacts on the wider family members that aren't currently collected. And if we can get any data sets that allow us to do that and then make some reasonable modeling assumptions where data can't be prospectively collected, I think that would help drive forward progress in this area.
I think one of the real challenges is getting evidence of impact of treatments on carers and external burdens. It's, you know, that's a step beyond showing the impact associated with different diseases. And I think it's a very hard thing to do because trials already put a tremendous burden on people involved in them. And it's hard to justify adding further and further tools. I used to work in clinical development and I've had these arguments with my clinical colleagues. So we need to recognise it's a difficult thing to do and to be kind of, I think, open in modelling approaches and be very inclusive in our consideration of evidence. I'm personally quite interested in the use of qualitative evidence as well. We talked earlier on about the heterogeneity in impacts, and we obviously have quantitative tools to try and estimate these impacts. I think there is a role for good quality qualitative studies as well to provide context and help that deliberative kind of discussion that goes alongside the quantitative. But again, I have a PhD student looking at this at the moment, but most of the submissions focus on the impact of disease. Relatively few of the qualitative pieces of work have looked at the impact of treatment.
I'm conscious of the time, and so perhaps the last question here can be a fairly dramatic one. One of the questions asks, everyone is making it clear that considering care or quality of life is a very difficult thing to do. Do the current methods make consideration of this issue better, or do they make our understanding of it worse in any way? Are we making it worse than doing nothing?
That would be my question, because I would be very concerned that considering quality of life would maybe, hold treatments back, depending. Yeah. So in that case, it would be better to do nothing. But if we can find a way to make it a positive thing, then yeah, that would be the way forward.
Then final word from everyone then, please, if you can give me a very brief answer of response to Portia's statement.
Oh, sorry. Go ahead, Neil.
No, you go ahead, please.
I think we should. I think we should try moving forward. What I see sometimes happens, even in the review by Becky Pennington and her colleagues, was sometimes things are considered not so often the caregiver quality of life, but often we don't collect it, or we're at the table and making quick assumptions, or it's a short trial or a DCE, and trying to throw it together. So Harith was alluding to this earlier. If we agree that this is something that should be included, we should collect it prospectively. We should try to gather the best evidence that we have, and really try to get to the table with a better perspective, whether that's quantitative or qualitative data. But I think there's an opportunity to bring that perspective to discussions in HTA.
From my perspective, evidence and data rarely hurts in principle. Of course, it may hurt individual treatments if they don't show strong impacts on carers. And that brings me probably to my wider kind of Grinch-like point that not everybody can be a winner. In the fixed budget world, if we do decide we're going to spend more or prepared to pay more for those treatments, which do have, important carer impacts, that may well mean we're willing to pay a bit less for those treatments that fail to show those impacts and improvements on carer burden. So yes, in terms of being more accurate in our allocation of that fixed budget, it's very important, and evidence will help, those treatments potentially win and show and demonstrate that we should be prepared to pay more for them, because in doing so, we're helping not only the patients, but those around them. But there well may be losers as well if we do that.
Yeah, I mean, I would just say that evidence, and part of that being the health economic evidence, is only ever one input into the decision-making process about A, whether a treatment is funded, and B, whether it's appropriate to deliver it to an individual patient or family. And it's always overlaid by that sort of deliberative discussion, and then an assessment by a care professional in the family about the individual circumstances. So I think it's really important to collect that information on how things impact on carers. Otherwise, we can never have this sort of evidence-informed discussion. But whether there are other factors that need to be taken into account when making final decisions, then there are ways to do that as well, I think.
Thank you, each of you. Thank you, Portia, Harith, Simone, Neil. That was a very interesting discussion. I would love to carry it on for another hour or so, but out of respect for everyone's time, thank you very much for your participation. If I can summarize one thing from this series of 3 webinars, is that this is an ongoing challenge. I think we all agree that it's important to consider it. It's difficult to consider it, but it is absolutely important to consider it. Hopefully we can reconvene here in a year or two and have some fantastic solutions to some of the problems we've discussed today. Otherwise, I look forward to future developments in this area. And thanks for your participation to the panelists, and thank you to everyone who joined online.
Thank you very much.
Enjoy the rest of your week.
Thank you very much indeed. Bye-bye.
Thank you.
Bye-bye.